Goniometry, Foundation for Evaluation, Differential Diagnosis, and Prognosis. Objectives. Students will learn about goniometry's reliability and things that impact reliability. Students will know and be able to apply the 12-step process and technique for conducting goniometric measurements to the joints of the upper extremity, lower extremity, and the spine. In this course, we're just going to focus on upper extremity and lower extremity, but you will already have this presented to you before you get to the spine courses. So we're going to talk about reliable goniometric measurements. What makes goniometric measurement reliable? And what are the different types of reliability? So when we talk about goniometric intra-rater reliability, what we're actually talking about is a measure of how consistent an individual or observer measures joint active range of motion. So intra-rater reliability consists of you being consistent, you as the therapist being consistent with the measurements that you take of a joint active range of motion amongst each individual patient. So for example, I'm the patient, right? Okay, come on, Emory. Let's see what Emory got. All right, so Emory, I'm sitting right here. You're gonna take a measurement of my hip external range of motion. And you're gonna take it 3 times on either leg, whichever leg you want to instruct me to do it on. Okay, right leg. All right. As I'm presenting this, I'm teaching you all as well, right? For lab practical purposes. So one of the items that we check you all off on is biomechanics, proper biomechanics. If he kneels like that, is he gonna get all the points for that? Most likely he's not gonna get any of the points. So this is just teach and learn. It's okay, Emily. I'm just going through it. All right. All right, so go ahead. External rotation.
Lined up with the anterior aspect of the patella. The distal arm is anterior midline of the lower leg, and then this proximal arm. The distal arm is proximal arm perpendicular to the floor. Distal arm interior aspect of the lower leg. So when you're ready, you're going to turn your knee outward like this.
So turning my knee outward or moving my leg inward? Which one would you rather say?
Move your leg inward.
Because this is my leg. My tibia and fibula is considered the leg.
So you move your leg inward.
And another thing, he said proximal arm and distal arm. I don't mind that. I can internalize that. But what I prefer to hear is stationary arm, movable arm. Write that down. Because then I can, as doing the practical, I think myself and Dr. McClure, we can process that easier. Stationary arm, movable arm. All right, I think that's how it is in Norkin and White. What did Norkin and White say? Proximal and distal. Okay, so, and just explain which one is which for me. All right.
So where you can do that movement. Thank you. You're at a 25 degrees external rotation.
Okay, do it again. And I want y'all to pay attention. If y'all may want to come around and pay attention to his alignment, make sure that his alignment is staying the same. Make sure his stationary arm is not moving. Because if your stationary arm is moving, right, it's going to throw your measurement off. And Dr. McClure and I are coming to look to see if you keep your stationary arm still. All right. When you read your recording, make sure you keep your goni in place. Don't pull it away. Because if you pull it away, what's going to happen? There's going to be some minute movement. There's going to be some movement to occur.
You can do that motion one more time.
What'd you get?
0 to 30 degrees.
Okay, do it one more time.
External rotate. Zero to 30 degrees.
Okay. So, would that be good intra-rater reliability? Yeah, he got about the same thing each time. The only difference, in the first one he got 0 to 25 degrees. Now that could be due to being cued not to move the stationary arm. It also could be due to your patient. As they do it, the more times they do it, they may get better range of motion. But I felt like I got the same range of motion each time because my hips are still. I got tight iliopsoas muscles. That I'm gonna get y'all to work on eventually. All right. So now, yes, sir.
Does it matter if you ask them to go ahead and do the motion and then place your goni on them, or you want the goni to stay on the whole time?
So I would like the goni to stay on the entire time throughout. Now go through your Norkin and White. Norkin and White, you need to keep the goni in place and read the recording before moving the goni away. Okay, all right. So that's good. So now, all right, Kira. Oh, go ahead, Dr. McClure.
Is that also because you're measuring starting position with the 0 or whatever? It's just to determine that you are starting at 0.
Yes, thank you, Dr. McClure. That does clarify because you want to get your starting point and your ending point. So you want to clarify that you're starting at 0. So yes.
You know what joint you might not start at 0? Like any thoughts? Potentially, or the one that comes to mind to me would be like thumb. Like you may not be it, you may be starting somewhere else and having to do some.
Thank you. Yep. All right, Kira, come on up.
Dr. Water?
Yes.
So that, I don't know, you only have a towel? Or no?
Okay, so that's a good question. So repeat your question again.
Do you have to have a towel?
Yeah.
All right. Now she said, do I have to have a towel under my hip?
Yes.
According to Norkin and White, if the hip, I think, is less than like 60 degrees, then you want to put a towel to increase the range of motion of the hip. So right now, my hip is probably in an adequate position to do it without a towel. Somebody pull up Norkin and White and let's fact check that.
I think it's like.
Read what it says.
It says, if the femur is not 90 degrees flexion, then place the towel roll under the distal end of the femur.
Okay, that's it. So if the hip is not 90 degrees flex, then you place a towel roll under the hip. So what do you think? Looking at me, do I need a towel roll?
Yeah.
So I probably need a towel roll. So go ahead and do the towel roll. Mhm. So you get a towel roll, then go a towel roll over there. So now I say, go off that Norkin and White. Fact check, you know.
That's what John style we use.
That's Pujan how you use. That's all right. You may need a bigger towel, but we'll just go through the process of doing it just for sake. But that did help. All right. So now, different reasons range of motions could be different. That's in the presentation, right? This is a reason why her range of motion measurements could be different than Emery's. Because with Emory, I didn't have the towel, all right, to put my hip at 90 degrees. So that could cause a difference. We're gonna see, we don't know. All right, hip external range of motion 3 times.
Okay. Alright, you're gonna bring your leg in. Go ahead and bring your leg in.
Okay, go ahead and explain your
Where?
alignment.
Okay.
Get used to doing that.
Patella.
Where's the anterior tether? See,
The fulcrum.
there you go. I'm telling y'all gotta verbalize it.
Stationary arm is on the, nope. It is perpendicular to the floor, and then distal is in line with the anterior.
There you go. That's it, Kira.
Alright, now bring your leg in. I got 40.
Okay, you got 40?
Yeah.
Is that correct? When she taking her practical?
0 to 40.
Okay.
Alright, bring your leg in again. I got 40. 0 to 40.
Okay, so you have it. We're creatures of habit.
Alright, and bring your leg in again. I got 40.
All right.
0 to 40.
All right. Now, what's she gonna get on the practical? What's what Kira gonna do on that practical? I'm gonna sit back and see. Okay.
Yeah.
So now, with her being consistent within her measurements, right, that she is taking, that would be an example of intra-rater reliability. Now, how would we establish extra-rater reliability? Yeah, so different therapists who take the measurements are then gonna compare the measurements to see if they're in the same ballpark. So what did Emory get?
0 to 30.
0 to 30. She got 0 to 40. Now, based on your Norkin and White, typically, a 5-degree difference, that's not bad. A 5-degree difference with inter-rater reliability. So a 5-degree difference, inter-rater reliability, is typically not bad. And I think Norkin and White even goes up to 10 degrees. I think it's like 5 to 10 degrees, something like that, in the section where Norkin and White talks about reliability. But the numbers vary, so it's all kind of numbers in that section. But I think it is safe to say anywhere between 5 to 10. And the closer, the better. So if the closer the difference is, the better the inter-rater reliability. Okay, does that make sense? All right. So now with that being said, if Dr. McClure, I think you are like way off base, and one of us will stand up. First thing, we're gonna come stand up and look at your alignment of your goniometer to see if that's correct. And then what I do a lot of, I would take the measurements myself as well. Pay attention to your goniometric readings, like the numbers, whether you're referencing the red numbers or the black numbers. Some can make a mistake with that as well.
So we use a hand to stabilize the limb that's moving. That's only for stability. That's not to like progress the motion at all.
Yes, it's only for stability. So many times when patients lack range of motion, they're gonna try to compensate somehow, in some way. So that's where your stabilization comes into place. So for example, I tell patients all this time when I'm looking at hip internal, external range of motion, you know what patients wanna do? They wanna do this. They wanna lift the hip, they wanna lift the thigh off of the plinth to get extra range of motion. So you see how much extra range of motion I get? But I'm also recruiting my iliopsoas. Guess what's the secondary motion of the iliopsoas? What is it? External rotation. So a secondary motion for iliopsoas is external rotation. So if they lack external rotation, what are they gonna try to do? They're gonna try to flex the hip, because the iliopsoas secondarily is an external rotator. So what you have, I tell the patient, keep your thigh, don't lift it, don't move it, and just move your leg so that it looks like this. So look how much, I get much less. But if I do this, I get much more, right? Okay, so now we have to know, like Seth said, you know, when to stabilize, where to stabilize. Sometime if you have a tech, if you're privy to having a tech, you can get your tech to stabilize certain areas so that the patient doesn't try to compensate. And you get a more accurate reading of what the patient's range of motion is at whatever specific time. All right, so again, this is a 12-step process. You get the patient in an appropriate testing position. You stabilize the proximal joint segment. You can perform passive range of motion and get an in-field assessment. Make a clinical estimate of what the likely active range of motion could be. Then you return to the starting position. All right. Then you palpate your bony anatomical landmarks, align your goniometry, read and record your starting position. This is what Dr. McClure was talking about. So that goes back to Tavian's question, and Dr. McClure helped share some more detail on that. So you're going to record, read and record your starting position. It says remove the goniometry. You can keep it in place. You don't technically have to remove it, but you just want to read and record your starting position, stabilize the proximal joint segment. Then you instruct the patient to move the distal segment through the full range of motion to measure the active range of motion. All right. Now you can measure passive range of motion as well. You can put a number to passive range of motion. So you could passively move the distal segment through the full range of motion to measure the passive range of motion. Now, if I'm asking you to quantify a person's range of motion, active range of motion, are you gonna move that person passively? Yo, do not make that mistake. So we do get students where we say quantify the active range of motion or quantify the range of motion. Now, I would specifically say passive range of motion if I want you to do passive range of motion. So if it just say quantify the range of motion, what are you quantifying? Active range of motion. All right, so I'm telling you right now, the reason why I'm going through this presentation is I will let you know if we want you to quantify passive range of motion. So assess active range of motion and have the person to actively perform the motion themselves. It says replace and realign the goniometry, palpate anatomical landmarks again if necessary, read and record the range of motion. When you read and record the range of motion, please leave the goniometer in place when you read and record your range of motion, okay? What happens if you remove the goni? It could change, okay? It could change. They're gonna, you know, there's probably going to be some little minute movement, which gonna allow the reader not to be as accurate as it could possibly be. So keep the goniometer in place. Now, if you remove the goniometer and you read it, this is for you to know in advance during the lab practical. Will you get the full points? Gabrielle say no. Yes, you will not, because I'm going to notate you remove the goniometer and read your findings. Whereas we would like you to keep the goniometer in place and read your findings and give the report. All right. This is your reference. This is your hallmark reference, all right, for every joint, which is Norkin and White, and what to do. So going back to review the hip, which is good. Thank you, Kendall, for pointing it out. We want to use the towel roll so that the hip joint is at what degrees? 90 degrees. So good. Board exam content as well. The test questions for the National Physical Therapy exam come from where? The textbooks. So if you go to the website, you will see the textbooks, the Federation Board of Physical Therapists. If you go to the website, you will see the textbooks that most programs use. Most programs use the same textbooks for a reason, because the test questions are being pulled straight from the textbooks. All right. And so if you get students who don't know how to, well, I ain't gonna say don't know how. The students get here, they know how to read. But if you get students who don't like to read and do not want to invest time in reading and apply strategies to reading, did y'all get the strategies that I sent out? Yeah, use those strategies. I still use those strategies to this day. And so if you don't like to read and don't want to read, or you refuse to read, then your chances of being successful on the National Physical Therapy exam it can decline if you don't do that. Because in your physical therapy programs, it's so difficult to try to teach every single thing. So you gotta read, take notes, you gotta do active reading, you can't do passive reading. So you gotta read with a purpose. You gotta read with extrapolating questions, turning content into questions. There's so many things to make the reading active versus just highlighting. Highlighting is kind of passive. So, because you're just highlighting and you end up highlighting everything. Okay. What questions do you have?
So when we do Gonnie, anyway, let's check my question, sorry.
You said when we do Goni.
Oh, yes, okay, so in the practical, would you want us to verbally say where we would stabilize if they had any, other, compensate?
Yes. So where you would stabilize or how you would instruct them. So it may be that you can't stabilize because both of your hands are on the Goni. So now you're gonna have to instruct them. And so, for example, in the case of hip, so in the case of shoulder abduction, right? You get patients who do this. Shoulder abduction. You say, oh, let me see you do right shoulder abduction. They go. What are they doing? They're trying to get a couple more degrees with right shoulder abduction by trunk side bending to the left. You see, they do all kind of things, you all, believe me. So now you're gonna have to give a command, keep your trunk straight. Don't move your trunk, I just want you to move your arm, okay? So that's real life from the clinic. I'm giving you a real life example of what patients have done to try to get more range of motion, okay? All right, with hip flexion, this is what they do. If you do it where, if you say you're doing manual muscle testing, or I'm just saying manual muscle testing, or even Goni, but most of the time Goni is done supine, but I'm gonna tell you all kind of things they do. They lean back on you. You know, they got all kind of little tricks that they try to do to get more range of motion at a specific joint. All right. What questions did you have? So we've gone over what? Manual muscle testing versus muscle selective tension testing. All right. Go ahead, Emery.
Can you kind of explain inter-rotator reliability a little more?
Okay.
I'm trying to get the difference between intra and inter.
Okay, so this is good. I'm glad you stopped and asked that because you want clarity on that. And this can be a research question that you get on the National Physical Therapy exam too, because this is research content. So your research course should cover this. You should know the difference between inter-rater reliability from your research track. All right. So intra-rater reliability, you as the therapist consistently get the same measurement over and over and over. Okay, you as the therapist. Now when we talk about inter-rater reliability, you along with other therapists get a consistent measurement over joint range of motion. That's inter-rater reliability. So if Acacia take knee flexion, Tabian take knee flexion, Zai take knee flexion, Z take knee flexion. All right. Kiki take knee flexion. If all y'all take someone knee flexion range of motion, it should be within at least a 5 to 10 degree difference according to Norkin and White for inter-rater reliability. Okay. So now, if you take knee flexion and your knee flexion active range of motion is 120 degrees, Taylor come back and take it on the same person is 110 degrees. Acacia come and take it, she only gets 90 degrees. Liz take it, she say, I get only 80 degrees, 0 to 80 degrees of range of motion, right? So Liz gets only 0 to 80, you get 0 to 90, Taylor you come back, get 0 to 120, and then say a Cajun come and get 0 to 110, then there is no inter-rater reliability. Because y'all numbers are so vastly different that you can't say that there's inter-rater reliability. Does that make sense? But say all of you all, say Tatum gets 0 to 121, you get 0 to 125, Liz gets 0 to 120, and say Acacia gets 0 to 123. Is that inter-rater reliability? Yes, that's inter-rater reliability because you all are just a few degrees different in difference. Okay, but that's a good question. Now, I want to go back and recap manual muscle testing. Now, when we talk about manual muscle testing, inter-rater reliability is going to be more likable, or more of, you gotta have a greater potential of achieving inter-rater reliability with manual muscle testing. Inter-rater reliability may be poor. Why is that?
It's so subjective.
Yeah, everyone's strength isn't the same. I always call manual muscle testing, I consider it subjective objective. That's what I refer to it as, subjective objective. It's subjective in nature to the specific physical therapist who's performing it. So Dr. McClure may manual muscle test somebody based on her strength that she has and get a different manual muscle testing score than what I get. So she may manual muscle test Kendall, and she may say, oh, Kendall is strong. Kendall is a 5, I got a 5 out of 5 with hip flexion. Then I come, I say, well, let me see what I get with Kendall. And I get down and apply my force, I say, oh man, Kendall about a 4 minus, or 4 out of 5, or 3 plus out of 5. I didn't get a 5 out of 5, Dr. McClure. But the difference is gonna be a difference because of our physicality, our strength, and the force that we apply, and how we interpret that finding. Okay? So manual muscle testing can be a tough one to try to establish inter-rater reliability. Okay? So that's why when we assess our patient with manual muscle testing, it's good that for the reassessments that the same therapist is doing a reassessment. Because if another therapist comes back and does the reassessment, you've done initial examination, then another therapist comes and do the reassessment or discharge assessment, then it may not, there may not be any reliability there. All right. So what have we gone over so far? Yeah. Yeah. There we go. All of those are foundations for what? Examination, differential diagnosis, and prognosis. That is 60%, mostly 60%, a lot of people say that foundational content is likely 60% of the National Physical Therapy exam. If you don't have a strong command of it, you put yourself at risk for failure. Now, if you have a strong command of the foundation, where do you put yourself at? You put yourself at, give yourself a higher chance of being successful, okay? What questions do you have? Notice I asked that about 4 to 5 times, most of the time. All right, that's it. Let's take a break.